And I've requested Dr. Sonu GOEL to take the opening batsman's role, and he will be speaking on refractive surprises after laser vision correction, what to do.
So thanks, Gaurav, for making me part of this course. So I'll be sharing one of our interesting case that we recently accidentally happened with us. This 26-year-old girl had a refractive error of -8 with 0.5 SIL, 180 degrees, and the routine investigation, as we do for all refractive surgery patients, were done. The PECI was close to 553 and 557, indirect ophthalmoscopy, MS39, LipiView, epithelial mapping, the Claris pictures, this is the topography, the pentagram pictures, and this is MS39 and the eye trace, and this is the macula, the fundus photograph. So everything was done, the patient was planned and discussed, and the patient wanted a lenticle extraction. So we took this patient on the Smile Pro with a cap thickness of 110, minimum lenticle thickness of 15, and an OZ of 6.2. So this is how we proceeded with the surgery. This is the Smile Pro, and routine docking once the patient interface has been docked in. And this is how the wonderful center align and the ocular-align system helps us to align both the cylinder and the center on the visual axis. Cut, the lenticle cut, side cut, the cap cut, cap side cut, entire process taking around 8 seconds. A routine dissection that we follow, I usually use this sharp dissector, separating the two planes, going first underneath the cap. I'm sharing this new technique that we have devised. This is called the inside-out technique, and courtesy to Dr. Gaurav Luthra as well for teaching us the hydro expression. So what we do differently is we go underneath the lenticule and leave two stumps from 10 to 2 o'clock, which remains undissected, and push in. This is the two stumps left here and here, and we push in a small jet of BSS, and the lenticule comes inside out. From 6, it expresses out, and then we can slowly pull in. And the beauty is that it gives you in toto the lenticle extraction, hardly any patient of 340 eyes that we did. So what this patient had to give us on day 1, the expected was 20/20 both eyes. Fortunately, in the left eye, the patient got 6/6, but unfortunately, in the right eye, the patient had 6/60, and we took this patient for the entire gamut of diagnostics, where the refractive error on day 1 was -5.25. So for a patient fixing for -8, the residual was -5.25 with some amount of residual cylinder as well. So this refractive surprise for all these patients that you do, check in for refraction, you check in for your epithelial mapping, tear film analysis, wavefront aberrometry, topography, tomography, OCT. So the entire gamut of tests were offered. What surprisingly, during this, we found out that the fellow who had recently joined us, instead of feeding for the right eye -8, she said, I misread 8 and 3, and she put in -3. So the clear undercorrection came up with us. Now the patient was a little fussed. He had to travel abroad. So he had a period of 7 days. We discussed with all the options, gave him an option to come back to us after 3 months, and then we could do it. But then we reviewed literature, how early can we do this? So the enhancements options after myopic smile, this wonderful article in the APO speaks of all the options available. Though the enhancement rates after smile routinely are very low, but this was a OOP situation. So we thought of discussing with the patient and working on the 4 different options: the PRK, the femtosecond LASIK, secondary smile, and the circle. So we discussed with the patient about the PRK, but since on the PRK platform, it was a -5 diopter error, and we had made a cap of 110, and since the patient had to travel, so though this was the easiest way, but when you are taking enhancements on the PRK platform, pain and delayed wound healing and a little haze that can, expect could be there because you're using a mitomycin C on top of a SMILE patient. So we didn't err in favor of PRK, again discussed with the patient, so the downsides and the advantages. And a quick look onto the literature came up of a concept of what is called as a secondary SMILE, where you actually do no anterior dissection, but just push in a posterior dissection and remove this. Since the whole concept was new to us, we did not err for that also, and we went in for what was called as the circle. So enhancement for SMILE, converting the cap, we thought we could convert into a flap, and we planned this patient for a circle enhancement. So the recommendation of the circle, as is the inner diameter of the lamellar cut should be approximately smaller than that of the existing incision. The overlap should be large enough, and the upper and the lower depth of the junction should be chosen so that the possible depth range in which the edge of the existing incision could lie, taking into account the these were the 4 different patterns, but the pattern D is the most commonly which is being used. So this patient was then taken after a week on the circle. The refractive error remained unchanged. The epithelial map did not give much of changes. So we planned on the 7th day. And so this is how the circle software helps in, this is the docking on the Pro platform, and hardly 4-second procedure. And the essence is basically converting the cap to a flap. And once this was taken, the patient was then moved on to MEL 90. Once this, just watch very carefully, only the peripheral rim has to be separated, because essentially the cap has already been separated once the lenticule has been removed. So very, very carefully we separate this, and now this cap, so-called cap now, a flap can be lifted, and the patient was then shifted to MEL 90 and the excimer was done. So this was how we were able to address the outcome, and the patient could regain 20/20 the next day. A quick word for all the cautions that we thought of. So the most important thing is feeding in the right data, accurate refractive measurements, accurate patient selection, patient ruling out thin corneas, high refractive errors, corneal irregularities, dry syndromes. Intraoperative factors are very, very important because there could be some errors with flap thickness, decentered ablations with the excimer. When you have a surprise, there could be cap-related issues. But for me, the oops could be with the fluctuations, the energy fluctuations in most of the excimer platforms. So the temperature and the humidity and the hydration of the tissue is one very important factor which could give you that day one oops in most of these refractive patients. So moving into the literature, we just came in with one good idea, and this was a concept that when you relift for the flaps, chances of epithelial ingrowth is usually very high, which ranges between 2 to 43%. So femtosecond platform on a retreatment is very important, and the flap diameter should be 1.2 millimeters smaller. The flap should be around 10 micron thicker than the original peripheral flap thickness measured by the anterior segment OCT, and the side cut angles taking 90 degrees with the hinge angle, the hinge being at the same place, and the hinge angle at 50 degrees could help in preventing this one of the disastrous complications. So as you see here, this was one of our own patients where we did a retreatment, we did raising the flap, and you see how bad was the epithelial ingrowth. So in such situations, the dictum is quite easy. You need to relift the flap, and you have to take care of the epithelial ingrowth, which is stuck most of the times onto the bed and the undersurface of the flap. So carefully debridement of the epithelium here, and I use the blunt surface of the 15 blade and gradually remove all the epithelial debris from all around, and I also scrape 360-degree the epithelium so that there are no further chances of the epithelium getting inside, and then we address the undersurface of the, keeping it launch and very carefully removing the debris of the epithelium I usually use alcohol for few seconds onto the bed and then wash and then replace the flap. Drying for some extra seconds is a good idea whenever you're trying to relift the and putting a bandage contact lenses. Sometimes you can use sutures if you feel, and this is how the day one picture looks like. Thank you very much.
Wonderful, Sonu. You've kind of summarized so many things for us. But I had a question for you, and I wanted to ask you that has your management for enhancements over a prior LASIK, changed over the years? Like, what were you preferring to do 10, 15 years back, and how do you want to do it now? Has there been any change? Like, would you like to go on the surface, or you always like to do a flap lift? What's your preferred way, and has there been a change over the years?
So I think it depends upon the primary procedure done for all the smiles that we have done, though we do not have any long-term outcome since we've been doing smile for the last 5 years, hardly find any patient where the enhancement was actually required. But yes, since we have circle and for minor diopter, maybe half or maybe one diopter, I would do a surface on top of a smile. Otherwise, I would err in favor of the circle and then taking the patient onto a excimer-based system. For most of the LASIK patients that we have, unless and until it's a major dioptric surprise or enhancements required, I would still relift and very carefully, as documented, take precautions so that there is no epithelial ingrowths and do a LASIK flap relift and enhancements. For PRK, again, PRK gives a good option for any low dioptric correction, and that's specifically for those kind of fitness patients that we have done maybe a couple of years back, and they still have a residual of half, or when their re-medical happen in their the services, they would come to us with some kind of a regression of maybe half a diopter, one diopter, where they have been, made unfit on their existing jobs.
Excellent. And do you look at the epithelium maps when offering, and what's the significance of looking at them for a LASIK or a PRK enhancement?
So I think that's a very valid point, and epithelial map is mandatory. We have that MS39 equipment with us, which actually gives you the thickness of the epithelium, and sometimes it could be an ectatic cornea or a keratoconus, which is, kind of masqueraded by the abnormal thickness of the epithelium. So it could be some kind of abnormal epithelium which is actually causing that refractive error. So at times it could be just the dry eye. So I think all in all, epithelial mapping in today's world, whenever you have a surprise or whenever you have kind of a residual refractive error, is mandatory in all these patients.
It's if there is a hypertrophic epithelium, as you said, with the MS39, you can get a thickness of the epithelium as well as the epithelial refraction as well as the minus the stromal refraction. If it's essentially, sometimes if it's just the epithelium which is hypertrophied, I would even just debride the epithelium, wait for it to regrow and see, reassess what is the refractive error and then decide.
That's a great idea, and I mean, adding some lubricating drops and just waiting for a couple of months and then rechecking the refraction and rechecking the epithelial map, or just simply debriding the epithelium works very well in these patients.
Thanks a lot, Sonu. That was really useful.